symptoms is deeply connected with nurturing spiritual well-being. Today, for about 20 minutes, I will share how modern palliative medicine approaches can complement your traditional symptoms in addressing pain, sleep disorders, and anorexia so that together we can further improve the quality of life of our patients. Okay, why this topic matters? Pain, insomnia, anorexia, they are most distressing symptoms in the chronic patients, especially the cancer and other chronic disorders like HIV, chronic neurological disorders, respiratory disorders, and heart failure patients, and also in elderly people. Why we are stressing on these symptoms only? It's common in cancer and elderly care. Untreated. Suppose you have a patient who is suffering from pain. You have not treated, then what will happen? It will reduce the quality of life of these patients and also suffering not only for the patient and also for the family members. This mitigation improves dignity and well-being for the patient and for the caretakers. So today in 20 minutes, I am talking about the modalities of pain management, like pharmacological drugs, what do we use in modern medicine, and non-pharmacological for the sleep, pain and anorexia, and what other interventional procedures we can do to reduce the pain. Why assess pain? Why do we assess pain? Anybody? Because you have different backgrounds now. Why do we assess pain? Because pain has different pathophysiology for each the types. Like nociceptive pain, neuropathic pain, you have a different pathophysiology, different mechanism of action, so that you need to identify before treating the patient. That's why you have to assess pain. What is the definition of pain? International Association for the Study of Pain describes pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Sensory, you know, what is emotional? Why do we have to stress on emotional? Because in palliative care, we are not only dealing with the physical aspects of pain, we are dealing with psychological, social and spiritual, the four components called as total care. That's why here in the definition itself they are saying, so it could be an unpleasant, emotional or sensory component. Dr. Robert Twycross, who passed away 6 months ago, he said, pain is what the patient says hurts. How do you differentiate pain? One is acute and chronic pain. Acute pain means it is sudden in onset when there is a duration is less than 3 months. And then you say pain is acute. When the duration is more than 3 months, you can say this pain is chronic. Example, acute pain, like patient is coming to the surgery for acute appendicitis. Post-operatively, 4 days, 5 days, he will be out of the hospital. That is an example for acute pain. Then chronic pain, patients with chronic disorders like cancer. So they will be having pain from the time of diagnosis till the death. We don't know. It could be intermittent or it could be continuous. Cause, as I suggested, usually identifiable fracture, burn, infection. Then chronic pain causes could be cancer, neuropathic pain could be diabetic neuropathy or arthritis. Purpose, it alerts the body to harm and promotes healing. Patient will be fine after the once you remove the cause. But in the chronic pain, it's a non-protective, so he loses warning function. So these are the accompanying features. You can say hypertension, tachycardia in the acute pain. So when you see in ER, patient comes with myocardial infarction, then you can say tachycardia, hypertension, sometimes you can identify. But chronic pain, no, they will be coming with sleep disturbances. I have not slept for more than 20 days, 50 days. Sometimes they say more than 15 days, I have not slept. I have not eaten anything. I am in severe pain. No one has recognized my pain. Those are the symptoms. Then no pleasure in life. They said, I don't want to go to anywhere. I don't want to talk to my friends. I am in pain. I don't want to go out of this house. They say. And personality also change. They will be isolated in the room, not talking to anyone. So these are the symptoms you can see with chronic pain. Chronic pain, one is CCP's cancer chronic pain and cancer non-cancer chronic pain. We have divided into nociceptive and neuropathic pain. I am not talking about pathophysiology today. I am just going in brief. Nociceptive, we have divided into soft tissue pain, bone pain, smooth muscle and skeletal muscle pain, and visceral pain. Here neuropathic, we have peripheral, central and sympathetic. What are the features of nociceptive pain? How do you identify this patient is having only nociceptive? Somatic is a well localized. See, pain is a subjective. Whatever the patient say, you need to accept it. You cannot say, oh, you are. If patient is having pain, you cannot say, okay, you don't have pain, okay, go. This is a subjective aspect. Somatic pain will be sharp, aching and throbbing type. Visceral, it's a diffuse and colicky, like myocardial infarction or some liver pain. Capsular stretch, you will be having the diffuse capsular stretch pain. It's a localized, aching and sharp type. Features of neuropathic pain is a neurodermal distribution, altered sensation or absent sensation. Sometimes when you touch the patient with a cotton swab, he will say he is having more pain. You can say altered sensation in the touch. How does the patient describe here? They describe it could be burning or pricking or numbness, pins and needles. These are the symptoms they can say. These are the, how do you differentiate nociceptive, neuropathic and mixed pain? Sometimes in the cancer pain, you can see both nociceptive component and also neuropathic component. That's why we called it as mixed pain. So you know, how do we assess pain? Everybody has their own assessment tool. So I am asking, what type of tool are you using to assess pain in your OPD? Anybody? First thing is, as I said, believe the patient, make him comfortable, observe expression and his posture. Detailed history. First ask, then listen. You say in the palliative care, listening is the main tool. You need to listen to the patient. Most of the time only doctors are talking to the patient, but in palliative care only we should listen to the patients. So specific pain questions, physical examination, assess non-physical issues, be non-judgmental. Do not assume in palliative care. Okay, never assume, okay, this patient is sitting quietly, okay, he is not having any pain. Never assume. Remember, while you assess him, he is also assessing you. What are the specific questions you can ask? So first one is sight. Where is it? Which part of the body are you having pain? Then second one, quality. What is it like? Present since. How long have you had it? Whether it is continuous or intermittent. These things you need to ask. Radiation. Is it localized in one place or does it spread or radiate to other side? For example, in MI, you say patient is having pain in the chest region. Sometimes they come with only the shoulder pain. Then severity. What is the intensity of pain? What are the precipitating and aggravating factors? What brings it on? What makes it worse? Relieving factors. what makes it better. Sometimes they say, no, if I apply cold, if I take cold bath, my pain will come down. If I don't eat, my pain will come down. Like that they say. While assessing pain, see, you cannot ask all these questions. You may forget. So that's why we made a code, PQRST. P is precipitating factors. What makes it worse or better? Quality of pain. Can you describe your pain? Your pain could be like pricking, burning, or throbbing. So you need to describe your pain. Whether it is radiating or relieving. Does it spread to other parts of the body or it stays in one place? So you need to find out. Then severity. How intense is your pain? It can be mild, moderate, or severe. Time duration. When did it start? How long will it be there? So these things you need to ask. Next, once your history is over, then you need to ask about the medication history. Are you taking any drugs for the pain management? Then what drug, what type, how much, whether it is orally or injectables. How often do you take? Sometimes they say, I take once in a week. Whenever the pain comes, I take the medications. Then the pain won't be there for one day. Afterwards again, pain occurs. Then effect, did it help? What are the side effects? So why? How has the pain affected you? See, while busy OPD, we are only assessing the unidimensional. Like we'll use the scale and then we'll assess. But we will forget the other part. Like how has the pain affected you? Are you going with the family members? Are you attending some function? We are not at all bothered about that. Then the daily life. Are you taking someone to have in your daily routine? We are not asking that. Appetite. How is your appetite? And sleep. Pain, appetite, and sleep. These three are interconnected. Once the patient is pain, appetite will decrease, and then again sleep will decrease. This is the cycle. So, what are the different types of scale we use in our practice? One is numerical rating scale. This is a scale with 0 to 10. Anybody can read this 0 to 10. You can ask 0 is no pain, then 10 is severe pain. Then how do you rate your pain on the scale? Then they say, okay, if it is 3, you can consider based on that. 1 to 3 will say mild, 4 to 6 moderate, and 7 to 10 severe. This is very simple, quick, and easy to document. Only thing is patient can read the numbers. Next one, verbal rating scale. This scale is can use for any patient. Like just you ask them which word best describes your pain. None, mild, moderate, severe. This one anybody can tell. Okay, my pain at present is now moderate or severe. Next one is visual analog scale. Here this is also a format, is especially sometimes it uses with the pediatric patient and also the patients who are unable to read the numbers, so that they can see the different facial expressions. Again, 0 is no pain, 1 to 3 is mild, 4 to 6 is moderate, and 7 to 9 is very severe, and 10 is excruciating pain. So based on this, we will divide the intensity like mild, moderate, and severe. This one, Wong-Becker, this mainly uses for pediatric children under 3 years. We have the scale, you can show the scale to the child. Okay, can you identify where is your pain? So he will identify whether it's green, yellow, red. Based on that, you can start your treatment. Advantages of this scale is it's a visual scale and cross-cultural use. You can use it to any patient. Next one, flag scale. It's face, legs, activity, cry, and consolability. It's an observational scale. Again, each category scored 0 to 2. It's best for infants and the children less than 3-year-old and non-verbal patient. so that you can use the scale in ICU setup also. Okay, is our assessment of pain complete? Now you have taken the history. You know now you used the PQRST. You know what type of pain. Depending on the whatever the patient say, you will come to the conclusion that okay, this patient is having only nociceptive pain or neuropathic pain. Okay, now you need to ask other aspect. I told you impact of pain on quality of life. So how about your sleep and appetite? Okay, are you going out with the family members? Because we are not worried about that. We are worried about only the pain. Because in the busy OPD, you will ask patient will be coming. You are using only unidimensional approach. But when we use the multidimensional approach, then we need to ask about the impact of pain on quality of life so that you can assess completely. Multidimensional pain scale is a detailed pain assessment tool. It measures pain characteristics, quality and location of the pain, and also functional impact, how pain affects daily activities, sleep and overall well-being. Psychological aspects like mood, anxiety, depression also can be assessed while using this scale. Behavioral components, how a person expresses their pain and how others respond to it. Sometimes patients caretakers. Once the patient is having pain for more than a week or 15 days, they say, this patient, the caretaker will come and say, Madam, this patient is having pain continuously, he is not allowing us to sleep and he is not also sleeping, what to do? These are the scenarios. So even the caretakers also expresses their concerns. Examples of multidimensional pain scales, one is McGill pain questionnaire and another one is brief pain inventory. We use mainly the brief pain inventory in our department. Benefits is a comprehensive assessment, personalized treatment and improved patient care. So once you assess physical pain, then you need to assess psychological, social and spiritual aspects. What are the spiritual aspects? Like guilt, why me? They ask many questions. Once the pain comes down, they started asking these questions. Madam, why me? I'm not a smoker. Then why I got CA lung? They'll come and ask how to answer to these questions. I'm not an alcoholic. I got CA pancreas or HCC, hepatocellular carcinoma. So these are the questions. It's very difficult to answer. Sometimes they say like emotional adjustment disorders, anxiety and depression, frustration and hopelessness. You can imagine 70-year-old lived very well in his life. He was diagnosed with CA prostate recently. Imagine. So he will lose the dignity and the position also in the family because he is unable to move. He needs to come back for the treatment. So somebody will taken over his responsibilities. Then he will be like, Madam, I am nowhere in because I am the eldest person in the family, but still I am nowhere now. Nobody is asking anything for my suggestion. They are all doing their own thing. So these are the things you need to address, like adjustment disorder, sometimes hopelessness. I was there now even I am there at home, but they are not taking my suggestions or guidance. Then social distress over family members, carers, loss of role, same participation issues. Usually, physical pain will address with the drugs like multimodalities, causes variable degrees of distress, interferes with other aspects. Once the physical symptom is controlled, then we'll start dealing with the psychosocial issues. Okay, I told you before, there are three modalities we are going to talk in any symptoms. One is pharmacological, another one is non-pharmacological, and third one is interventional. The pharmacological, we follow, this is a WHO ladder, World Health Organization ladder. We started using since 1986. We have three steps here. Step 1, step 2, step 3. Step 1 means once the pain is mild pain, then we start using the step 1 drug. If the pain is moderate, means if score is between 5 to 7, we'll use step 2 drugs. If the pain is severe, more than 7, then we'll use step 3. I'm not going in depth. These step 1, you have main paracetamol and NSAIDs and adjuvants. These are the adjuvants you can add in each step. It could be steroids, anticonvulsants or antidepressants. Step 2, weak opioids like tramadol, codeine, tapentadol, buprenorphine, they all come under step 2. Then step 3, we have strong opioids, morphine, fentanyl and methadone. Then next I said interventions. It again depends. Nerve blocks, RFA and spinal drugs pumps we can use. Non-pharmacological, physical therapy, psychological interventions and lifestyle modifications like yoga, meditation, etc. Now the second symptom what I have is sleep disorder. Insomnia is common in these patients. Once the patient is in pain, they cannot sleep. So what to do now? First you have to reduce the pain. Still patient is having insomnia, then rule out other causes of insomnia before putting them on drugs. We have different types of drugs. Otherwise then CBT, then sleep hygiene, you need to change their lifestyle modifications. Those things you need to adjust. Okay, then supportive modalities, relaxation training, stress reduction, physical activity, limiting caffeine and screen time. I have a patient now, 16-year-old, diagnosed with stage 4 renal cell carcinoma. She pain is well controlled. Now her sister's worries, madam, she's not sleeping regularly. She's getting sleep at 2 o'clock and 3 o'clock. When you ask her, she said, madam, I was watching TV or I was using phone till 2 o'clock and 3 o'clock midnight. Definitely you don't sleep. That's what we have to adjust their life modifications. The last symptom is anorexia. Anorexia again, if patient is having difficulty in sleep or having more pain, then anorexia is also one of the problem. So these are the drugs we can give. But one thing is, as a Ayush physician, you can adjust the nutritional support, give small frequent meals, encourage enteral feeding and then parenteral nutrition. Supportive modalities like treat again underlying cause. It could be pain, nausea, depression or vomiting also. Counseling and family education, dietitian support and integrating digestive or tonic remedies from traditional symptoms. I'm concluding with the pain. See, once any time patient comes with the pain, take the history in detail. Don't neglect any aspect. Otherwise, you cannot assess whether this pain is a one component or it has mixed pain. Once you assess, then it's very easy to treat the pain. Otherwise, patient will be having anorexia and then sleep problems. Different types of modalities you can use. See, only drugs will not help in these patients. You need to counsel them and sometimes you have to change their lifestyle modifications. Integration with Ayush strengthens care. Aim is we have to provide dignity, comfort and quality of life to the patient and also the caretaker. Thank you.